The Hip Fracture Registry has been a great collaboration between Australia and New Zealand. There are many registries that lie wholly within countries, but there's very few registries that cross borders like this. And it's been very successful. From the start, we've been able to engage clinicians and all stakeholders on both sides. And when we prepared the clinical care guidelines, these were prepared in conjunction with the Australian Commission on Safety and Quality in Healthcare and the equivalent commission in New Zealand, which was a first. The registry itself runs very well. It's separately funded by both Australia and New Zealand, and we've been able to do it in a collaborative way so that all the results can be presented in one annual report. Yeah, the ANZ Hip Fracture Registry was built based on the model that was developed in the UK, and they have a national hip fracture database there that started several years before we did. And we were lucky that we were able to piggyback on their success and use some of the people that were involved in the development of the UK's registry in our registry. The UK has shown considerable success in all of the indicators, and they've shown year-on-year improvement, for instance, in hospital mortality and early mortality after hip fracture, but also time to theatre and many other indicators of quality of care. In Australia, there's been a particular focus from the federal government on clinical quality registries, how these should be run, how they should be funded, and what the value is from registries such as the ANZ Hip Fracture Registry. In fact, the government produced a report recently on the evaluation of the economic cost of clinical quality registries, and they actually found that establishing clinical quality registries to improve the care of people is a positive economic benefit, such that it can return up to $7 for every dollar invested in these registries in healthcare savings. In another lead from the UK, this year we decided to begin reporting identified hospital names. Previously we just reported numbers, and we wanted to make sure that we got the registry well established and that the hospitals were happy with the data they were seeing. So this year we offered the hospitals to have their names produced in the annual report. We thought that some hospitals would agree, and we were very surprised to find that nearly all agreed. This is a great step forward for transparency, and to be able to see a hospital name next to their performance carries a lot more weight when the hospital is trying to improve their performance. They can see that their results are now publicly available. The goal for the registry is now to work more closely with sites. We plan to roll out hip festivals where hospitals can get together and learn from each other about methods and techniques that they've been able to establish to improve their care. We're going to also work more closely with sites so that they can see areas for potential improvement. And we want to be able to document that improvement and help drive that improvement. And finally, we want to do more research with the data that we're now able to collect. The ultimate goal, of course, is to improve all of the quality indicators that we measure in the registry so that people with a hip fracture can be treated in a timely manner, in the best possible medical management, with good analgesia and the best functional results. As a surgeon, I treat a lot of hip fractures, and it's very common for me to see patients come back with a fracture of the other hip after we'd previously fixed a fracture perhaps 1 or 2 years earlier. This is a common problem, and this annual report has really highlighted to us that we're not doing as well as we could in preventing a second fracture in patients who present under our care. This is an area that we need to focus on, that we need to work with sites and we need to work with governments about how we can improve the treatment of osteoporosis to prevent another fracture from occurring. Another strength of the registry is that it has been able to provide data back to sites that they have been able to use to address problems they have with the timing of hip fracture surgery. So, for example, we know that about 50% of the delays to surgery are due to what we call modifiable factors. These are delays in getting theatre access or not managing their medications properly prior to surgery. Hospitals have been able to take that information, go back to their executives and use that as an argument for more resources for operating rooms to get people fixed quicker.